Hello, everyone. Thank you for joining us today. Our webinar is titled Telehealth Billing and Coverage, What's In and What's Out. My name is Cassidy Avila. I'm the Program Coordinator for the Texas A&M Health Rural Engagement Program. Before we begin, just a couple of notes. As you saw, we're recording the webinar and we will share a copy of that recording with you, as well as a copy of the slides in a follow-up email. We would love to hear your questions and comments today, so please feel free to share them in the chat as they come up, and we'll make sure to address them at the right time during the webinar. We've also set aside time for Q&A at the end. It is now my pleasure to introduce to you Joy Krusch, Senior Manager with Eide Bailly. Joy has more than 30 years of experience in healthcare, with an emphasis in coding, health information management, compliance, charge capture, and documentation improvement. Joy assists clients with the day-to-day reimbursement challenges that they experience. She's also experienced with the revenue mid-cycle, including documentation improvement, charge capture, and coding, and she helps clients maintain compliance practices. Joy also has experience with managing denials on the back end. She has served as president and in several other positions with the North Dakota Health Information Management Association, and she's currently a member of the American Health Information Management Association Revenue Cycle Practice Council. Joy, thank you so much for joining us today. We are honored to have you here. It is all yours.
Okay, sounds good. Well, thank you everybody for joining us. So today we're going to talk about telehealth, billing and coverage, and kind of what's in, what's out. The physician final rule is out. The OPPS final rule is out. So I've been going through that. Had gone through the proposed rules and now looking at the final rule to see what may have stayed, what may have changed. So the first thing there we go. We do have a disclaimer, that this is not intended to be legal advice. Definitely, things are changing rapidly, and one of the things, that could change is if Congress acts here in the month of December. So always look at what the current information, check with your legal, accounting, or other professional advice on particular situations. So we're going to talk a little bit about the overview of Texas. I'm just going to give you, every state that I look at, right? Each state has some kind of regulation posted about telehealth. And so I'll just kind of go over that high level. Talk about, current Medicare coverage and billing guidelines and what our future looks like. Definitely, I will say on the congressional action, the big thing that's looming here, right, is that if we do not have congressional action before December 31st, telehealth in patients' homes will not be able to be performed. There's lots of speculation out there that is not something Congress wants to let happen, that it definitely has bipartisan support. So we're all very hopeful, but we're still kind of at the edge of our seats waiting, right? We'll talk about behavioral health because that has some rules that are in place that protect it. We're going to talk about AMA's new telemedicine E&M codes and what that means. We'll talk about licensure, a little bit on digital E&M and virtual check-ins, and then just some documentation considerations. So again, just a little bit about in Texas insurance code, the health benefit plan must provide coverage for a covered healthcare service or procedure delivered by a preferred or contracted health professional to a covered patient as a telemedicine medical service. And they include even teledentistry or telehealth service on the same basis and to the same extent that the plan provides coverage for the services in an in-person setting. So they cannot exclude services delivered by telemedicine, and they may not subject to limit, deny, or reduce coverage for services provided via telemedicine. They may require deductible copayment or coinsurance for a covered healthcare service provided via telehealth. They're not stating that that is in any way waived. They're just indicating that the amount cannot exceed the amount that we would have if we were in person. And each issuer of a health benefit plan shall adopt and display on their website their policy and payment practices for telemedicine medical services. So just if you were looking for an insurance company within Texas, that should be very visible on their website. One thing with Texas, there's no reference to payment parity, which means insurance companies can have different fee schedules. They can pay for telehealth at a lesser rate than an in-person rate. There's nothing that in the state that says they have to pay for it the same. This is really state to state. It wasn't that long ago. I think I was in Washington looking at their rules and regs, and they do have payment parity. But in the state of Texas, they do not. So let's talk about Medicare and telehealth. So obviously during the PHE, individuals with Medicare had broad access to telehealth, including their homes. The whole geographic or location limits were not applied, so we didn't have to have a patient located in a rural in order to be able to provide that service to the patient. And then, when the PHE ended, the Consolidation Appropriations Act extended many of these flexibilities, and that's why today we're still doing many of the things we did during the PHE. And obviously the big thing was the geographic area in the United States, that we could do it in their homes, and then allowing FQHCs and RHCs to be distance sites. All was extended, but this is what now is kind of these 3 bullet points are what we very much need congressional action on in order to move forward in 2025, because we don't have a Consolidation Appropriations Act right for 2024. So we need something to further this along. So again, if no action is taken, we'll be back to pre-pandemic rules. We do want to point out, though, that there's exceptions, and that is the behavioral health services. That was something in the Consolidation Appropriations Act that was made permanent, and then also ESRD assessments were also pre-pandemic. Those will still be available. There's been lots of pieces of legislation have been introduced. I think the problem is we don't know which one will be picked up. In all legislation, there is allowance for telehealth. There is not another thing that I'll bring up in this presentation that is in all legislation that is a little bit concerning and may impact providers, but we'll talk about that in future slides here. So again, for Medicare, we want to always look at that Medicare telehealth list to understand what services will be covered by Medicare. We do see a lot of Medicaids in particular publishing lists. They're very similar to Medicare, but again, they have their own lists. So as you look at your state Medicaid, or if you look at commercials, some of those commercials have lists as well. The updates to these lists, if you remember during the public health emergency, things were getting added throughout the year. That will not occur anymore. It's going to be through rulemaking, and that usually is through the physician fee schedule rule. In 2025, they talked a lot about things that were proposed to be added. There were some that they did add, and we'll see that in a future slide. But one of the things that when you look at this list, you'll see that there's permanent and there's provisional. So permanent, That will not change. Provisional could go away, and CMS still again in 2020, for our 2025 year, was not ready to make those permanent. So we'll have to continue to look at that in our 2026 rule. Um, individuals and facilities that use these codes that are provisional are encouraged to write CMS for those rulemaking of why we think those should be made permanent. And those comments need to be by February of 2025. So we really don't have that much time to get those comments in. So again, when CMS looks to add on a permanent basis, what they're saying is it needs to be clinically equivalent to something that's already on the list. And if it isn't equivalent to already what's on the list, what's the evidence that assures us that, the clinical benefit is sufficient for it to remain on the list or to allow time for confirmative study? So here is the list. It really has not been, you can see it was updated in November 2023, effective January 1st. So it was updated after the last final rule. I don't see a new one out there yet. So this will be something we all want to watch. And what we'll kind of really want to watch too is what they do with that can audio only interaction meet. Are they going to change that at all? That'll be something we'll want to watch. And again, you'll see the categories provisional or permanent. So some of the new services, and this should say not proposed because these were added. I apologize, I didn't change my title there. But these have been added. So they're no longer proposed, they are added. So when we look at GO 248, they stated in the rule, they added that as provisional. So that's not permanent. They want to see evidence of why that should remain on. GOO 11 and GOO 13 were added as permanent, so those will stay on. And then what I couldn't find on the caregiver training and the group behavior management, these were added, but in the final rule, I couldn't find the language if it was provisional or permanent. Maybe it was on other pages and I just didn't pick up on it, but that's something we'll be able to tell on that telehealth list when it gets updated. But for 2025, these codes are available to us as telehealth codes. So as far as the audio only telehealth, meaning we're doing it without the video, the Consolidation Appropriations Act of 2023 extended that availability. And so we were able to use 99441, 2, and 3. So those codes, if you've looked in your new 2025 CPT book, those are deleted. So those codes are not available to us. So we're not going to be able to use those. We're going to have to look at that telehealth list. And again, that's where I think we're going to want to watch if they make changes to audio only. I have a feeling that they may, based on some of the language in the rule. So something we'll want to watch. So, and this is why. So in the rule, they stated we're finalizing as proposed to revise the regulation to permanently change the regulatory definition of an interactive telecommunications system to include two-way real-time audio only technology for any telehealth service furnished to beneficiaries in their home if the distance site provider is technically capable of using an interactive telecommunications system, which includes audio and video. We clarify no additional documentation except for the appropriate modifier as, so that's the FQ and the 93 modifier. So this language makes me wonder if the audio only yes or no is going to go away and that this language is going to replace that and say, as long as we have the capability on the distance site, the provider, as long as the service can be provided in the same manner as an audio only, we'll be able to do that. So just something to watch. Again, this is one person's interpretation as I was reading that. So we'll want to see how that plays out. And again, in RHCs and FQHCs, the G 2025 always has included audio only. So for rural health clinics, if we did an E&M as audio only, we just billed 2025 anyway. And we just had to append our modifier. And so 93 was for RHCs and FQHCs, and then others were using the FQ. So these are modifiers that we'll continue to use. So again, let's watch this audio only and see if that changes. And then also just keep this on your radar because CMS did note the following, that, the audio video telemedicine E&M codes have nearly identical recommended work RVUs to parallel office E&M codes. So right now, CMS is not changing how they're going to pay E&Ms. They're going to pay them based on how they've always paid them. But there is chatter out there, I guess is for lack of a better word, is that the specialty societies are saying, well, the audio video doesn't quite require as much work, or excuse me, I said that wrong. The audio video and in-person visits require more work than the audio only. So that's really why the AMA came out with those new codes, but CMS is not going to use those new codes. And so at this point, there's no payment change for us from a Medicare standpoint with our services, whether we do audio only or audio video. Let's touch on the RHCs and the FQHCs. Again, I just kind of go back to where it all started with the CARES Act. And then the Consolidation Appropriations Act extended that authority. So once again, we're waiting on something to continue that authority. I don't know that we're going to see anything permanent. I think we're going to see this kind of that can kick down the road more. We have heard possibly even 2 years, which would be nice, giving time for maybe more permanent rulings. But for the RHCs and FQHCs, we've reported the G 2025 with modifier 95. For medical visits, we do not count them for the cost report. The behavioral health visits are different. That did have permanent ruling, but for medical visits, we're really kind of still where we were at, and it's going to stay this way for 2025 as well. So again, we bill G 2025 for 2024. We're looking at $96.87. I haven't yet found the 2025 rate. Includes charges for all revenue codes of the 52X, and we do not use the CG modifier in our RHC because we are not getting the AIR. Still, we're paid similarly as on our AIR. We get 80%, and then that 20% is the patient responsibility or the co-insurance. However, the difference is the 80% is based on the fee schedule amount and not the AIR. And then Medicare Advantages, we really have to, it's going to be plan to plan. And then our commercials will typically accept the regular E&M codes. So just some of the comments in the final rule, the eliminating flexibilities for RHCs and FQHCs, they feel would cause disruption in access. They really strongly are pushing to preserve the flexibilities. Again, they don't have the authority to do that. They want time to engage parties while we consider how to incorporate different technologies in a more permanent basis. So what they're saying is, again, if Congress acts, they're going to continue to allow the RHCs to use the G 2025. They're not looking to make any change at this point to allow RHCs to bill the E&M and get their AIR. That's just not going to happen no matter what in 2025. And they're going to continue to calculate that payment amount based on the PFS. They kind of do a weighting of all the services. They believe this would preserve telehealth flexibilities for RHCs and FQHCs, that have been furnished for over the 4 years and would not impact access to care. But again, as you probably have heard me say this now 5 or 6 times, it's all based on congressional legislation. One thing I did want to mention, we do see providers doing annual wellness visits via telehealth. And, other than the couple of blood pressure, weight, height, there is no exam. So they do kind of lend themselves to a telehealth list. These were on the list even prior to the public health emergency, and they continue to be on. They are listed as audio only. So we do see some providers definitely doing these annual wellness visits. And this could be in the RHC or this could be in the provider-based clinic. I mean, freestanding clinic. This isn't just really only for RHCs. It could be any. The thing is, for the annual wellness visit, though, we do still report the G2025, and then we have to report that modifier CS, which, we think about, well, that was a modifier we used during the public health emergency. Well, it's also had other meaning outside of the public health emergency, and it waives the coinsurance on the G2025 because we don't want the patient to have to pay 20% on this annual wellness visit because it's a preventive service. So just a little bit again on the CS modifier to be aware that it has an alternate meaning, and it does mean that deductible and coinsurance are waived. The other thing that's been a little bit of a challenge is if facilities are part of like an ACO, and they have attribution requirements for annual wellness visits and preventive services. The bad thing about G2025 is that they can't get their attribution. They have to come up with a manual method to track that. So that is one downfall of the G2025. Eligible providers. So these are eligible providers. You will note marriage and family therapists and mental health counselors are on here. What you will not see on here are therapy. So physical therapy, occupational therapy, speech therapy. We listed the marriage and family therapists, the mental health counselors. They were that was a new benefit category in 2024. So what was nice about this was when they added them to be able to bill for services under Part B, at the same time, they said, okay, we're going to add them to the eligible list of providers that can provide telehealth services. So they did it at the same time, which was, again, I think it's Medicare's commitment to behavioral health. They made sure that this wasn't something that fell through the cracks. So that was good news, and they will stay on that list, and that will not go away. However, PT, OT, and speech, so the CARES Act kind of waived this Section 1834 that allowed for them to be able to provide telehealth services. Then the Consolidation Appropriations Act, it did not permanently change, which was kind of unfortunate. It only extended it. So initially this waiver impacted therapists who practiced independently. Then we had the Hospital Without Walls that provided hospital therapists to be able to provide services. So in 2024, we had the PFS rule address that. So really kind of what happened, I should back up, is at the end of public health emergency, the Consolidation Appropriations Act had allowed therapists that were independent to continue to do telehealth. What we had was this kind of lapse from the end of the public health emergency until the physician final rule in 2024 for hospital therapy staff to be able to do telehealth. Well, then they kind of shored that up and they allowed for payment for outpatient therapy, DSMT, and MNT when furnished by qualified employed staff of institutional providers. So that allowed our hospital therapy, our hospital registered dietitians to be able to provide telehealth. So that they've been doing that in all of 2024. Well, unfortunately, in 2025, now the OPPS final rule comes in and they're addressing remote services with goal to align hospital employed staff to be allowed to provide services remotely, similar to provide providers billing independently. But now the final rule is saying, okay, these practitioners will no longer be able to bill for services. So unless Congress makes a change, unless they extend the OTPT speech beginning January 2025, they will not be able to provide services. Now, in the rule, it also says DSMT and MNT, which if you go back to my eligible provider list, registered dietitians are on there. So they are eligible providers. The problem is so many of our registered dietitians are employees of hospitals. So we're back to those hospital employed registered dietitians not being able to provide these services. So I think this is going to be very significant. I mean, I work with hospitals, particularly, well, that do both therapy and medical nutrition therapy services remotely. And so this could end unless we get something to come in place for this. So behavioral health, the good thing about this, right, was the Consolidation Appropriations Act of 2023. That really did a lot to address behavioral health. One of it was the coverage of the marriage and family therapists, and then also to be able to do those services via telehealth. In the 2022 physician final rule is where they address the use of audio only. And so it was back in that rule where they identified mental health telehealth furnished to beneficiaries in their home using audio only, and they gave us modifiers specific for that. And again, what they said was distance site practitioners must have the capability, but patient doesn't want to use it, whatever, they can bill for these services as an audio only. I do recommend, I mean, this came right out of the 2022 rule about documentation requirements. So I would want to have in my provider's note, if they do an audio only, patient doesn't have access, patient unable to make it work, patient does not want to use their video, whatever reason, to document that in their note. The other requirement that we were going to have, was when we have telehealth for behavioral health, eventually we may get to in-person requirements. I mean, this again is kind of keeps getting pushed down the road. Lots of conversation in the rule about, is it really necessary? I mean, there's pros and cons, I think. Some commenters state they feel it is necessary, others don't. But again, this is gonna be delayed. This was actually delayed through January 1st of 2026. So we will not have to worry about those in-person mental health visits the 6 months before and at least every 12 months until now, January or December 31st of 2025. We'll probably be talking about this again. And then the other thing was the prescribing controlled substances. Now this is all really kind of separate from CMS. This is under the Drug Enforcement Administration. And during the public health emergency, they adopted policies which allowed controlled substances without having that in-person visit. And then the Consolidation Appropriations Act of 2023 waived it until 2025. And then, excuse me, it was tied, but it was not addressed. Excuse me, it was not addressed in the Consolidation Appropriations Act. So then we had other rules. We had separate rules. We had a temporary rule that was May 11th through November 11th of 2024, which we were all kind of like, why would it expire in the middle of the month when everything else was to the end of the year? Then they came with a second rule and they pushed it through December 31st. So a new rule just came out, and this is going to extend this flexibility now to December 31st of 2025. So that has been put in place, and this is the link to that rule on that. And then for behavioral health for RHCs and FQHCs. So it's important to be sure if you're providing behavioral health in any of these clinics that in 2022 that changed, right? We don't bill those as G2025. We bill the CPT code. This is permanent. And the visits are counted for the cost report. We utilize the CPT codes per description. This in-person encounter, okay, that's now again in a different ruling or section of the rule that's been waived through 2026. But for behavioral health, for these clinics, we want to bill the actual services we're providing because we should be expecting our AIR. And then for behavioral health, the other thing that kind of happened is, during the public health emergency, we had hospitals with maybe therapists that don't bill individually, but they were providing some services out of the hospital. They were able to do that without through the hospital without walls. Well, that ended with the PHE, but the 2023 rule did come out and say, okay, we understand we've got some hospital behavioral health kinds of services being provided to patients. We don't want that to end via telehealth. And so they created new codes. These are permanent. This flexibility will not end. And we could, PPS hospitals use it, CAUSE use it. And it's these C codes, C7900, 01, 02. And then in 2024, we had one with 03 for group therapy. So hospital staff can provide these services remotely, and we can bill on the UB. These are very clearly remote services. Everybody knows what we're doing. Place of service. So if you're billing on other than a UB, right, we need to provide the place of service. It was in the 2017 rule, we actually had place of service introduced, and then a description change occurred in 2022. So O2 is telehealth provided other than in patient's home. So think about a patient in the nursing home. They're not located in their home when receiving the services. That would be an O2. In the 2020 rule, then we got the place of service 10, which is telehealth provided in the patient's home. So if we're providing services in the patient's home, we should be using 10. And these two place of service have payment implications if we're getting paid on the fee schedule. So again, in 2023, the final rule finalized the use of 10 and O2. And in the 2024 rule, they kind of finalized how they were going to pay this. So claims billed with place of service 10 in patient's home, they're paid at the non-facility rate. So they would be paid that higher of the fee schedule. Where services billed with an O2 will be paid at the facility rate. The theory behind that being is there is another entity helping to provide those services, and they may in fact be billing a originating site fee. We really don't have to report modifier 95 because the place of service tells us. And the whole language about, payment no longer as if service has been furnished in person, that's because the place of service is driving on the fee schedule how it's being paid. They did add this in the final rule about if you're dealing with a provider-based clinic, this is where this comes into place, right? And this this to me was kind of a little bit of a hard swallow because um, if I'm a provider-based clinic, um, and so then that means I have a facility-based clinician. I'm a hospital outpatient department of the hospital. They clarified in that was a 2024 rule that facilities have to use place of service O2 along with modifier 95. The unfortunate thing about this is that a provider-based clinic is going to get the facility rate, the lower rate, and they have nothing additional they can bill because they can't bill any kind of a technical. And that doesn't seem to have changed, and so just be aware of that. That's something that I mean, literally. When I read last year's rule, it was like one paragraph thrown in there that just kind of changed my whole thought process. Originating site, this really hasn't changed, right? We were doing this before. We should continue to do this now. If we're an originating site, we want to build a Q3014. And then these are the payments that we're going to be looking at in 2025, $31.01. Some facilities I know I've had conversations with are like, oh, this is such a low rate to have the patient on site. This is all I get. But one thing facilities have to kind of keep in mind too is if I have the patient in my originating site, and we're doing a distance site, right? And the distance site is billing. But if that distance site provider orders lab or x-ray, that comes back to my facility. So sometimes we have to look at that originating site as maybe the opportunity for additional services to be performed. Some frequency limits. So prior to the PHE, there was restrictions on how frequently we could do a service via telehealth. So for subsequent inpatient, we had once every 3 days, nursing facility once every 14, critical care once per day, and then ESRD had to be once every 3 months. The 2024 rule extended this telehealth frequency for the duration. And now 2025 is coming along and doing exactly the same thing. They're extending those. So we do not have those limitations in 2025 for these codes. Direct supervision. So if we were doing any kind of virtual direct supervision for pulmonary rehab, cardiac rehab, we were able to do that, during the public health emergency. Then the 2024 rule said, okay, we're concerned about abruptly discontinuing this direct supervision done virtually. So they pushed it down to end December 31st. The 2025 rule is again extending the ability now through December 31st. So the rule on these have not changed. They're just pushing them out another year. The one thing in the 2025 rule, though, they did discuss, and they are going to make permanent, is that there's some services that direct supervision can permanently be provided audio video. It's a subset of Incident to services. It's really only those services that have a PCTC indicator of a 5 in the Medicare physician fee schedule rule or Medicare physician fee schedule when you look that up, and then also CPT code 99211. They just discussed in there, and commenters agreed that these are usually done by auxiliary staff. They're very low risk. So is it really necessary to have direct supervision, or can these be via audio video? And that was made permanent. Teaching residents. So again, during the public health emergency, this is when a telehealth service is occurring, right? And we've got the patient maybe at home. We've got the teaching provider in one location, the resident in another location. We could do that all virtually. That was allowed during the PHE. It was extended in 2024. Once again, they're extending that in 2025. They haven't changed the rules on this. Again, virtual presence during the key portion. It continues to require real-time observation, not mere availability. It can't be that they're just available. They've got to be on that visit, and they need to document in the record, just like they do if they're in person, that they're present, through the specific portions of the service. So these are the new CPT codes in our CPT book. If you've looked at those and heard about those, there are new patient audio video codes, new patient audio only codes, established patient audio video, and somehow I missed there's established patient audio only. I don't know how I did that. I apologize. So all those codes are new in the CPT book. But CMS talked a lot about these in the rule, and they just didn't see that these are any different than E&Ms. They did not see a need to recognize them for payment. There could be assigned a status indicator of an I, meaning there's a more specific code. I think what we're going to want to watch is, what do commercials do? Are they going to adopt these new codes? And if they do, are they going to adopt these new codes to maybe differentiate payment between audio only and audio video? Because the AMA talked a lot about that. So just something to watch. Licensure requirements. So when telehealth is used, it's considered to be rendered at the physical location of the patient. So wherever that patient is, the provider has to be licensed in the state. This was waived by CMS, but so back in the day, we really had to kind of look at CMS's rule, we had to look at the state rule. And so during the PHE, both kind of waived a lot of these exceptions. And then I think CMS thought, why are we regulating this, right? So they really, at the end of the PHE, said, we're not going to regulate this. This is state law regulated. There's enrollment considerations that we have to think about for CMS. I don't want to have anybody miss that point. We have to have enrollment in the right jurisdiction. That remains. But as terms of licensure, we have to look to our states. And I look at a lot of state regs on this, and most of them require to be licensed within their state. Sometimes there's some things unique to bordering states, but you want to be sure if you have a provider providing telehealth services to a patient outside of your state, they need to be licensed in that state. Really, what kind of has helped this a lot is the Interstate Medical Licensure Compact. Many of the states, and it's, when you look at the map, it is most of the states. There's still a few that they have it in their legislator bucket to look at. It's not in place yet, but most of them have become part of these compacts, and this really allows, so I, as a provider, if I am residing in North Dakota and I want to be licensed in Minnesota, South Dakota, Montana, I just apply to the compact, and then I can go through that. It's kind of a one-stop shop. I got to pay all my fees. That doesn't go away, right? But I don't have to do as much paperwork with individual states. And when I talked to somebody in North Dakota that works with this, she said it goes so much quicker than the traditional way. So that's what most providers do, is go through this to get their licensure. And again, we have to look at the state by state. So for example, Oregon is one is noted as no status. So if we were providing services to a patient in Oregon, we would have to go through the traditional method. And I put the link here, which will take you right out to there, and you can see the map and see what states are part of that. Digital E&Ms, I just wanted to kind of mention, let's not forget about these, right? These codes are still out there. These really came right before the PHE started, and I think none of us really had figured out how to use them, and then the PHE and everything was just happening so quickly. So don't forget that these are available. These are online digital E&Ms for providers that can report E&M visits. We've got the 5 to 10, 11 to 20, 21 plus. Note for rural health clinics, they have one very specific code, which they report the G0071. The thing that's a little bit challenging about these is that we have to look at that 7-day thing. That if they have an E&M within the 7 days, we can't report these separately. This would have to be included in that E&M. And then we also have our brief communication codes on G2251 and G2252. Remember, these are initiated by the patient. So I call in or I put in something in the portal to talk to the provider. Those are those codes. And then we've had a brief check-in, which was G2012. Now, interesting, AMA did come out with a CPT code on this, 98016, right? Virtual check-in. And so CMS on this code did decide, okay, this code matches exactly what we have with G2012. So they are going to replace G2012 with 98016. So that is one code of the new codes of the AMA provided us that CMS will recognize January 1st. And then remote monitoring, I put this primarily in here is that I want to make sure we understand that this really isn't considered telehealth. So it's not under the same geographic restrictions. So no matter what happens with telehealth, remote monitoring will not be impacted. And it really allows our providers to monitor outside of our traditional care settings for remote physiological monitoring or remote therapeutic monitoring. We do have some requirements with the codes. You know, they have to be an established patient, consent required, billable once per month. We have to record at least 16 days out of 30. Remember, during the PHE, we could record less days. Think about our COVID patients and our pulse ox monitoring is kind of what comes to mind. But now it has to be 16 days. And when we think about these services, and if we've also got the patient enrolled in chronic care management, for example, they can be billed concurrently. We just can't use the same time. You know, those times have to be separated. And then just a few documentation considerations. You know, when I think about templates, sometimes I'm a little cautious on templates. I don't want to get too templated that we get, you know, providers just doing what's on the template and they don't do any free text. When it comes to telehealth, I think a header templated is very helpful. You know, where's the patient located? Where's the provider located? What was our modality? You know, did we have consent for the visit? You know, maybe there were other patient or other family members present. We should document that. Did we notice any safety concerns if we had video? You know, was there a family member assisting with that assessment? And then appropriateness of the telehealth. Why was this visit appropriate to be as a telehealth? That just covers us so there's no questions. You know, when that note is reviewed, that case was appropriate for a telehealth visit. So really, kind of in conclusion, you know, this really emerged during the public health emergency. It has, in some markets, really exploded. Probably all of us on this session today have used telehealth. I thought it worked great. Do I want to use it for every visit? No, but there's definitely visits where it seems very appropriate. It really is important for facilities to have a strategy to remain competitive because we don't want to lose our patients. We know in our commercial markets, right? Those insurance companies, they're getting their own teledocs. So we really have to think that through and have a strategy. Obviously with Medicare, you know, and our kind of limitations with waiting for Congress have made this kind of hard for facilities. But I do think we really want to have a telehealth strategy and dress for our future, how we're going to provide care to our patients, because it's not going to go away. And that is the end.
Excellent. Thank you, Joy. It is now your opportunity to ask any questions that you have. You can unmute. You can drop your question in the chat and I will read it for you. Joy, there was only one comment from earlier in the presentation that says there will also be specific changes as we become RHC's modifiers. I think
That there will be changes with modifiers. Is that what they said?
potentially, it looks like modifiers might have been one of the examples of some changes that would be to come.
Okay, okay. Yeah, I'm trying to think for telehealth. I mean, if, down the road, right? So with telehealth right now with G 2025, I don't know if I pointed that out clearly. Right, we don't use CG modifier because again, we're not expecting our AIR. But if we're doing behavioral health in the RHC, we would use our CG modifier. And then we want to use the modifier for audio only if we provide the service audio only. So those two nuances specifically. So if there's something more, please unmute and bring up whatever your question is on that or thoughts on that.
Thanks, Joy.
Yep.
Anyone else? While you are formulating your question, I'm going to launch a quick poll. I believe it's 3 questions, and you can do that while you're still on with us or as you are finishing up your question. And then I also want to give you a couple of websites, a couple of links. I am going to drop in a link to our website and let's see, one other thing for you here today. So if you want to learn more about how our program, the Rural Engagement Program, supports rural communities, hospitals, clinics, and providers, you can click either of these links, and this one right here will take you to our technical assistance inquiry form. You can use that short form to request more information on the types of free support that we offer Texas rural healthcare providers, including telehealth, and any of the information and topics that Joy has discussed today. And then here comes the website. I don't see any other questions, Joy. But if you do think of a question following the webinar, please don't hesitate to reach out. We can get a response for you, or we can put you in contact with Joy if necessary and make sure that we get your question answered. But we appreciate your time. Thank you, Joy. There was a lot of really great information in your presentation, and it was a pleasure being with all of you today. Thanks, everyone.
Thank you.
Joy, did you see there's a comment that says, very informative. Fingers crossed and prayers all of this permanently adopted. Absolutely. Thanks for the comment, Mark.